our last formal lecture then will be TB-HIV co-infection. It's a very important topic, especially for those of us in South Africa. As you know, TB is a very, very common occurrence, and TB-HIV infection is extremely common. As you know, I also work at a TB hospital at John Mackenzie, and at that hospital, over 85% of the patients admitted for TB are also HIV positive. So HIV and TB go hand in hand. It doesn't mean that everybody who has TB has HIV, but if you're sick with TB, there's a very, very, very high chance that you're also HIV co-infected. Okay? So we're going to be talking about why that is and a little bit about that in this lecture. Okay? So this is a big lecture because TB, I could give a 10-week course on TB as well. So I'm trying to cram all of that into one lecture. So I'm going to try to be as thorough as I can, but not going to extreme details about everything. This is sort of just to give you an overview of the topic, a lot of the important things about TB co-infection, but there's much, much, much more. I could, again, write a 10-week, 18-lecture course on this topic alone. Okay? So we're going to talk about the epidemiology very briefly in South Africa, talk about the natural history and pathophysiology of TB, review the clinical manifestations of TB, discuss diagnostic tools and dilemmas of TB. That's where we're going to spend a large amount of time. Discuss treatment of TB very briefly because that's pretty well regimented and most people know that fairly well here in South Africa. Review the dynamics of HIV-TB co-infection. When they're together, there are some important things that we must keep track of and must know about. And then discuss treatment options for HIV and TB co-infection. So TB is unlike HIV in many, many ways. One, TB is a bacteria, not a virus. And the other thing is TB has been around for a very, 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 very long time. HIV has not been around very, very long. The first known infections were only in about the 1940s and 1950s, and those were when they went back and looked at old blood samples. We didn't even know about HIV. It wasn't even found and it wasn't even named and figured out until the late 1980s. Okay? So HIV is a very, very new disease. TB is not. TB has been around for a very, very, very long time. Even prehistoric times, TB has been around. It has been suggested up to 1/3 of all of the world's population is infected with TB. So 1 in every 3 people in the entire world has TB infection. That's a lot of people. That's a lot of TB. Up to 40% of all the cases of TB in the developing world occur in children. So a lot of the burden is also in children. An active TB infection in children usually represents transmission from an infectious adult. Children themselves don't transmit TB very well, particularly children less than about 10 to 12 years old. They can't generate enough force in their cough to actually spread the TB around. So if you find a child who's positive with TB, the first thing you should do is find out where they got it, because it means that somebody who was around that child was coughing and gave that child TB. So you should be tracing family members, those that live in the household, to check to see who gave that child TB. The most common cause of death worldwide in HIV-infected people is TB. That's why it's so important. That's why this is such an important topic. Because people with HIV, they don't die of HIV, they die of something else. And that something else, very commonly, is TB. There are different things that weigh the risks of getting TB. Certain things highly increase your risk of getting it. So one of them is living in a high prevalence country. Well, South Africa is very much a high prevalence country. Healthcare workers, those of us who see sick patients, particularly those working in a TB hospital, have a risk of getting and contracting TB. Household contacts of those who are known to be TB positive. Somebody living in a household of somebody coughing up TB has likely also got TB because they've been breathing it in for long periods of time. Okay? Prisoners and minors, because they're all stuck together in an indoor situation with people coughing, and there's not a lot of good air ventilation and circulation in prisons and mines, so they're also in very, very, very high risk of getting TB. Okay. So this is an old graph now from 2004, but it just gives you a sense of an idea of what the types of TB infection and the amount of HIV and TB co-infection. You can see South Africa in terms of the number or percentage of TB, the incidence, the number of new cases of TB, that South Africa ranks very, very high, among the highest in the world. And HIV-TB co-infection, the percentage of them, you can see is a large proportion of those cases are also HIV infected. Okay. So if I say 1/3 of the world's population is infected with TB, well, 1/3 of the world's population isn't dying of TB. So how can there be this much infection? How can so many people be infected with TB but not really be sick with TB? And that difference really is in the difference between latent TB infection and TB disease. Latent TB infection means that somebody has TB living inside the body. So there is TB living, a bacterium of TB living inside the person's body. They haven't yet developed symptoms. They're clinically fine. They don't have any, they're not coughing, they're not losing weight, they're fine. And those people they're not infectious, they're not contagious, they're not going to spread TB onto other people. But they have TB. They are in fact infected with TB. And that's called latent TB infection. That's latent TB infection. Now that's different from TB disease, or what other people call active TB. These people have TB living inside the body, but it's causing a problem. They're sick. It's causing symptoms. These people are coughing, or they're having meningitis, or they're having a pleural effusion, or pericardial effusion, or TB abdomen, TB of the bones. They're having symptoms. They are sick. And if it's in the lungs, then they are contagious. There's a difference between latent TB infection then and active infection. Okay? So in an HIV-infected patient with latent TB infection, so TB is living inside the body, they have TB, but they're not yet symptomatic, the risk of developing active TB is 10% per year. This is the same as the lifetime risk for those who are HIV negative. So if you have two people, one is HIV positive, one is HIV negative. They both get TB, latent TB infection. The one who's HIV negative has a very small risk of actually developing symptoms of that TB. 10% in their entire lifetime. And 5% of that risk is in the first year. So if they don't get sick within that first year of getting infected, there's a very, very, very small chance of them ever getting sick in their whole lifetime. The other person who's HIV positive gets TB infection, and every single year they have a 10% risk of getting symptomatic and sick and active TB. So within 7-10 years, their chance of developing symptoms is extremely high. Extremely high. Because 10% per year of getting symptoms. Okay? So HIV-infected patients with a CD4 less than 100 have a 50% chance of getting active TB. So their chance is extremely high. Half of them will develop active TB, compared to only 10% in their entire life of somebody who's HIV negative. So that's the difference between HIV, latent TB infection, and active disease in somebody who's positive and somebody who's negative. So on average, 50% of close contacts become infected. Okay, of course, the range is 0 to 100. You're either not infected or not infected. But say you have a person who's positive, you've admitted somebody to the hospital, or you've diagnosed them in the clinic, and their sputum is positive with TB. There's 10 people living in that household. Well, those people in that house need to be screened because likely 5 of them are positive, at least. At least. So we need to be screening and asking patients when we diagnose them positive, who lives in the house? Are there children in the house? Because children have a much higher risk of getting TB infection than other adults. And have they been screened for TB? The lifetime risk of disease after infection is only 2 to 10%. It's very low. Half of the risk occurs in the first 2 years of infection, as I said. So if you've made it past the first 2 years, being HIV negative and you have TB infection, the lifetime risk then is very, very small. Okay. The same in infected infants is not true, and that's for adults is the 10%. In children, they have a 40% chance of getting symptomatically infected. So it's very, very high. And the risk of disease in HIV-infected people prior to the use of HAART, as I said, was 5 to 10% per year. It's much lower if they're on ARVs, but there is still a higher risk of them developing symptomatic TB compared to those who are HIV negative, even if these people are on ARVs. Okay. So that's a bit about the epidemiology. How common is it? How common is it in HIV positive people? And how common do they get sick? So if you're going to learn about TB, you have to know how does it occur and how does it work? How does it make you sick? Well, there's different transitions when you become TB infected. Well, first of all, you're susceptible. Now, what makes you susceptible? Well, everybody's susceptible. Nobody's immune to TB. So everybody's susceptible. And then you're exposed. What does that mean? It means that somebody who had active TB was near you, was around you, was coughing, was talking. You were in an area where somebody had active TB. So you're exposed to TB. If you're in that area and you happen to breathe in those particles, and you breathe in enough of them, then you're infected. If you're infected and you get sick, well, then you're diseased. You're diseased, you get sick, and then it's only at that point in time, particularly here in South Africa, only when you're sick can you be diagnosed. You have to, at least the current methods in South Africa for adults, is you have to present yourself to the clinic being sick, coughing, having abdominal pain, having meningitis, before you can actually be diagnosed. And then once you're diagnosed, hopefully you can be treated and cured. So what do we mean by exposure? Well, exposure is defined through contact investigation. There should be a recent contact within 3 months of a known infected patient. The best determination of this, and how do we tell if those that were exposed versus those that were infected? Well, the best way is the skin test, the Mantoux skin test, that we use to determine if somebody is TB infected. Okay. Oftentimes, people who are just exposed, they have a negative skin test, physical exam, and chest x-ray, all going to be normal. It's going to be normal. You're not going to pick these things up during this time period. Early exposure within the first 3 months. This period during which the skin test may be negative, even in a TB-infected person. So it takes time for that person to develop the reaction to the skin test, and that can take up to 3 months. So somebody who's exposed may be infected, but for the first 3 months, we can't diagnose it. That's sort of like the window period with HIV. Sort of like the window period. Their exam is normal, everything's normal, even the skin test is normal in these people, but they can be TB infected. Children, usually young children less than 5 years old, should be treated if they're asymptomatic, have a negative skin test, if they were exposed to TB. Because they can develop disease very rapidly, even before the skin test turns positive. Think about that for a second. I want that to settle in. Because this is something that we do not do. We do not do this well. This is in the HIV guidelines. It's in the TB guidelines for South Africa. But think of yourself in your mind, how many times have you seen somebody who has had TB, you've diagnosed them yourself, or you're a counselor and you counseled them on the first time that they were diagnosed with TB? And how many times did you ask them, do you have children under 5 living in your house? Because all of those children under 5 living in that house should be treated for TB. Not just check their skin test. They should be treated for TB. Something that we are not commonly doing. Particularly at the clinic level. Particularly the clinic level, they just do their job. They don't ask about contacts, and they don't ask about family members. But those children can get sick and get infected with TB. So all of their contacts, all children under 5, that is a contact, a known household member of that person, should be treated with isoniazid. Older children and adults are often not treated, but they simply get monitored skin test. So, TB infection. Well, how do we diagnose TB infection? Well, the hallmark is a positive skin test. Positive Mantoux test. This means there are germs living in the body. TB is inside your body and it's living inside the body. That's what TB infection means. That's what a positive skin test means. The chest X-ray is often normal. There's usually no symptoms, no signs, nothing other than the skin test being positive. Anyone with infection should be treated when the risk of disease outweighs the risk of serious adverse events from the medicine. And the medicine that we usually use is isoniazid. And then disease. Disease occurs when there's clinical progression or radiologic manifestations of TB infection. So these are patients who are coughing. These are patients who are losing weight. These are children who are developing lymph nodes, developing meningitis, developing pleural effusions, pericardial effusions, having TB of the abdomen. All of these signs, symptoms, they're starting to come out. These are people who are diseased with TB. There's 2 types of disease from TB. There's primary disease and reactivation disease. Primary disease means you get sick with TB, or you're exposed to TB, you breathe in the TB, you're infected with TB, and then you get sick right away. Within the first few months of your infection, you get sick. This occurs in that first 2-year period, usually in patients who are exposed and infected with TB. The majority of HIV-negative patients, the vast majority of HIV-negative patients, they are exposed, they get infected, and they don't ever progress on to disease. They have latent TB infection and they never get sick. If they do get sick later on, that's what we call reactivation disease. The disease occurs after a period of dormancy of the infection. You got infected, the TB was there, it was living inside the body, but the body has been able to contain it. It walled it off, and it's not making you sick. If something happens, those walls break down, and the TB can spread and make you sick, that's reactivation disease. The skin test is negative in about 10% of diseased patients. And it's much higher in severe types of TB infection, particularly miliary or even TB meningitis. The skin test can often be negative. And as we know, people with HIV and severe immune suppression with low CD4 counts, the skin test is also negative very, very commonly. So how do you get TB? How does somebody actually catch it? If 1/3 of the world's population, why is it so easy to get? Well, it happens because TB is in the air. It's an airborne disease. It's caused, and you get infected by breathing in the infectious airborne particles. TB then settles in the lungs because you breathe it in, and that's where it settles. And then the TB multiplies within the lungs, in the macrophages inside the lymphatics of the lungs. And activation of these macrophages leads to formation of granulomas, which are sort of like walled-off little cities of TB. Now, if your immune system's intact, they can sit there and live in those macrophages for long periods of time without making you sick. Organisms contained in droplet nuclei land in the alveoli, which are the end-terminal sacs of the lungs. The infectious dose is very, very low. You need to only inhale less than about 10 organisms. So it's very easy to get infected. Less than 10 organisms floating in the air is very, 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 very small. Organisms ingested by the macrophages, these parts of the immune system, are transported to regional hilar, which are in the chest, mediastinal, also in the chest, and cervical, up in the neck, lymph nodes, which are part of the immune system, okay, in the lymph nodes. And then it has two things. It can either stay there in the lymph nodes, your body can contain it, or it can spread. And it can spread anywhere. It can spread locally within the lymph nodes, or it can get into the bloodstream and spread anywhere in the body. So this is why TB is so contagious. This is a picture of a man sneezing. Now, all of these little things, now this isn't a TB, this is just, these are droplet particles. Each one of these would have millions of TB on it if this person had TB. And so you can see the number of particles that's released in a sneeze or a cough is a lot. It's extreme. All of these things would be infectious and contagious in a person who has TB. But this picture doesn't even tell the full story. Because most of these particles, this thick cloud here, they're big, and they drop right to the floor. But what the picture doesn't show is this cloud goes on and on and on and on and out here and out here and out here and down here. Those small particles can float around in the air for hours. If this person coughs inside a closed room or sneezes inside a coughed room, those particles can float around in that room for hours. You open the door, you're the next one in, and you can breathe it in. TB is an indoor disease. It's an indoor disease. This person coughs outside or sneezes outside, these particles get dispersed by the air and the wind. The chance of you breathing it in is very, very low. It gets carried away pretty quickly. TB is also killed by sunlight. So the safest place to be if you don't want to get TB is outside. Which is why we now have many of our TB hospitals and TB clinics have outdoor waiting rooms. So people don't catch TB in the waiting room. A lot of HIV clinics are doing that because the prevalence of TB among their HIV infected is so high. Here at St. Mary's, the waiting room is outside because they were getting lots of patients who were becoming infected in their ARV clinic with patients coughing or sneezing inside. So you cough, you sneeze, somebody else coughs and sneezes, you breathe it in. It goes down into the lungs and settles in these lymph nodes. Lymph nodes are located all along the trachea and bronchi, and it's going to settle in these areas. Well, the first place it will go is where gravity takes it. It will come down the trachea, and the trachea split into two bronchi. And right here is where a lot of these TB particles will settle, because it's the closest place. And it will enlarge in these, it will then go into these lymph nodes in this area. So, when somebody becomes infected with TB, these lymph nodes get large. And you can see them on X-ray, like here and here. This is what we call hilar lymphadenopathy. So the hilar is meaning in the central chest, the hilum, where the trachea breaks off. That's where a lot of these TB particles live, and they live inside the lymph nodes, and those lymph nodes get bigger and bigger and bigger as the TB makes more of itself and more of itself and more of itself. So one of the common things you'll see in somebody who's TB infected on an X-ray is hyaluronidenopathy, something like this, a widened mediastinum. Very common in patients with TB. Now they can grow so large, and this is a very common picture in pediatrics with TB, they can grow so large, these lymph nodes, that they can block off an entire segment of the lung. And that's exactly what has happened in this picture. The TB lymph nodes have grown and grown and grown, and it blocked off the upper segment of this lung. And this part of the lung collapsed. It's not filled with air, that's why it's white. It collapsed because no air could get in because those lymph nodes got so big. This is a common X-ray in a child with TB. Because the lymph nodes get so big, they block off an airway. And so you see a blocked upper airway. So how do we prevent it? Well, this is one good way to prevent TB. Hook the patients up here and vent it right outside. It says you don't want to infect all the other patients, do you? Well, this would be a very good way of not allowing TB to spread within your hospital. Because they're breathing, it gets vented right to the outside, where the particles are easily dispersed and killed by the sunlight. But it's not very practical. I'm going to skip that one, that's a bit confusing. So, once you get infected with TB, and you get disease, there's really once you get infected, there's really two things that can happen. You can either become sick and get primary disease, primary infection, or you can get immune control. And this leads to dormant TB infection, so this would be a person with latent TB infection. So you get infected, either you get sick right away, or your immune system keeps it in check for some time. So this is a graphic just representing that. Respiratory droplets of TB, they're breathed in, they go into the lung. You either have primary TB infection, get sick right away, or you have latent TB infection. Your immune system is controlling it. If you have primary TB, you can have progressive or disseminated TB. If you have latent TB, you might never get sick in your whole lifetime. You only have a 10% chance if you're HIV negative. If you're HIV positive, you have a 10% chance every single year. If you then get sick, that's reactivated TB. So primary TB infection. About 5% of people, even with normal immune systems, not HIV positive, they will not be able to contain the TB infection, and they're going to get sick within the first few months of TB infection. Without treatment, 40 to 50% of infants and 15% of older children will develop active disease within 1 to 2 years. So children do not tend to have that 10% lifetime risk. That's in adults. Children have a much, much higher, about half of them will get sick with TB within the first 1 to 2 years of treatment. Primary TB can occur in the lungs, it can occur in extrapulmonary sites, or it can be disseminated. It can be really anywhere in the body. Primary TB is much more common in children and in patients with HIV. Okay? These patients, children, the immune systems act very similarly to those with HIV because they're an immature immune system. They're not a properly functioning immune system. So children are much more prone to TB, and adults with HIV are much more prone to TB. Children with HIV have an extremely high chance of getting symptomatic TB because they have an improper, poorly functioning immune system that is getting wrecked and destroyed by HIV. So their chance is much, 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 much higher. So either you get sick in primary disease, or you get immune control. So immune control happens at about 2 to 3 months. Your cell-mediated immunity, the part of the immune system, can stops the spread of TB. It just goes to right in the chest areas, in the local lymph nodes, and it doesn't spread. TB infection becomes dormant in the body for an indefinite period of time. It could be a year, 2 years, 5 years, or it could be your whole lifetime, and you never get sick with TB. Although TB is dormant, there's still a risk of reactivation TB, especially if T cell immune function declines. Now, T cell immune function can decline because you get HIV infection. T cell immune system can decline just simply because you get older. As you age, your immune system and T cell function declines. Or you could get some other type of illness. You could get cancer. You could get diabetes. All of these things affect your immune system, and they can reactivate your TB. So are children with TB ever contagious? This is a question I get very, very commonly, particularly on the pediatric wards. What should you do with a pediatric child who has TB? Should you isolate them? Should you keep them separate from the other children? Are the other children risk from this child? Well, in a large, broader community question, it's hard to answer. It's hard to check. But what we can do is look at what has actually happened in the past. And in orphanages, if a caretaker, one of the adult caretakers, has TB, well, then TB spreads very, very quickly and very, very much through that orphanage. Okay. However, if a child has TB, gets brought to that orphanage, it doesn't very commonly spread through the other children. So it's not very common for these children to spread it. The same is true in school. There's only been a few epidemics where a child less than 13-year-old has been the source of the TB infection spreading through a school. It's more commonly to be an adult, teacher, or worker at the school that's spreading it to the children within the school. So in children's hospitals, it's very, very rare for children within the hospital to spread it to other children. It's just thought that children, small children, particularly those less than 13 years, don't have enough force, they don't have enough organisms in the body to actually spread it out to others. So the question is, if you're visiting the pediatric wards here at St. Mary's or another hospital, should you be wearing a TB mask if you visit TB patients? It's not really necessary, because they don't really generate enough force. They don't have enough TB really living in the body to actually spread it. Adults, that's another story. Adults are very contagious. So clinical manifestations. Children most commonly present in the first 5 years of life. Those that are HIV positive usually present much earlier. Much earlier. Now, TB can cause really anything. It can cause really any symptoms you can imagine. The most common thing in respiratory and pulmonary TB is a chronic cough, respiratory symptoms, and it's usually lasting a long period of time. Somebody who comes in with a cough for 1 or 2 days is probably not having TB. But it's a long process, a long cough. They've had cough for a long time. They might have blood-tinged sputum, sweating at night, losing weight, having fever, having big lymph nodes, particularly in children. Remember, TB can also cause meningitis, so they could be having headaches, changing personality, those sorts of things. And in HIV-infected individuals and in children, TB is much more commonly extrapulmonary TB. So not just located in the lungs, but also other places. TB meningitis, TB pleural effusion, pericardial effusion, TB abdomen, TB of the bone, TB of the kidneys. It can be any of these things. So primary pulmonary TB, many children have silent infections. They're not that symptomatic. They may have a chronic cough, something else. But it's not usually very as obvious as in an older adult. Infants are more likely to have signs and symptoms, and they're more likely to have disseminated disease throughout the body. Symptoms are commonly non-productive cough, shortness of breath, weight loss or not gaining weight very well, fever, night sweats. All of these things are very, very common. And as I said, in children, common signs on X-ray that you see are hilar lymph nodes. You can see some very nice right there. Or as those lymph nodes get larger and larger, collapse of an entire segment of the lung, like in this one. So reactivation disease is much more common in older children and in adults and in those who are HIV negative. Reactivation is much more common in these groups. And these are much more symptomatic and much more commonly present in the way you think the TB should present. More commonly with a chronic cough, fever, weight loss, night sweats, productive cough, maybe even coughing up blood. The sort of things you think about, the symptoms that make you think of TB, much more common in reactivated disease. Adults and older children can have extensive upper lobe disease on chest X-ray. And reactivated disease, much more commonly, is located in the lungs and limited to the lungs compared to primary disease, which is usually elsewhere in the body. So other TB can be of the spine. You can have non-painful large cervical or clavicular lymph nodes, which is very, very common in very small children. We see this quite commonly. They develop big lymph nodes that start draining. That is very commonly due to TB. Lots of things we should investigate for TB, particularly pneumonias, pleural effusions, pericardial effusions. Any child with meningitis, we should be considering TB as a possibility. Any child with very large lymph nodes, especially if they're persistent, especially if they're draining, we should be thinking about TB. And non-painful and large joints, you can have TB of the joints as well. So extrapulmonary TB, of course, we all know TB can occur in the lungs, but it can really occur anywhere else in the body as well. As a professor of mine once said, TB can actually cause anything but pregnancy. It can cause anything in the body. It can occur anywhere in the body. So TB really can be anywhere. It can be of the bones, of the spine, of the joints, TB of the GI tract, the liver, the kidneys, the adrenal glands, the respiratory tract, the male genital tract, the female genital tract. You can have TB of the skin. It can be really anywhere in the body. So a child with a very large persistent lymph node in the neck, that could be TB. So HIV positive adults with TB, it's what we're talking a lot about children, is because they behave very much like children with TB. They both have weakened immune systems. So HIV disease progression on TB treatment with and without ARVs. As I said before, TB progresses up to 10% per year in those not on heart. Heart alone can reduce the risk of progression of TB in latent TB infected individuals by as much as 80 to 92%. But it doesn't get rid of it. It doesn't make them equal to a person who is HIV negative. Their risk is still elevated. But ARVs and heart dramatically reduces their risk of getting TB disease. Patients on or about to start heart should still be offered TB treatment for latent TB infections due to long-term risks of failure. This is new to the South African guidelines in 2010. This is talking about isoniazid preventative therapy. This is talking about doing skin tests in all HIV positive patients. Those with a positive skin test should be given treatment for TB. And we're going to talk about that in the next few slides when we talk about diagnosing. So diagnosing TB in children and in those with HIV, it can be difficult. It can be very difficult. The best way to do it is with contact exposure to TB case within the past 2 years. If you know somebody who's been on TB treatment, they've had positive sputum, they've been to the clinic, they've been on treatment, well, all of their contacts should be checked for TB, the children and the adults. You could check their clinical symptoms. Are they coughing? Are they losing weight? Are they having night sweats? Are they having fevers? That's a very good way to check. The next best thing is to check the Mantoux test. Now, a positive test anywhere from 5 to 15 millimeters, depending on circumstances. HIV positive patients in South Africa, anything over 5 millimeters would be considered positive. An HIV negative person, anything over 10 millimeters. Since our prevalence is so high in South Africa, anyone over 10 is considered positive. And anyone over 5 if they're HIV infected. So we're going to talk a few minutes about the skin test itself. So what are the indications for the skin test? Who do we give the skin test in South Africa to currently? Who gets the Mantoux test? Children. Can adults get a Mantoux test? Yes. Why don't we use it then in South Africa? So this is exactly the answer I wanted to hear. Because most of the adults were immunized with BCG, right? So we can't do the Mantoux test. Were the children immunized with BCG? What age do we immunize for BCG? 6 weeks. So were the children also immunized for BCG? Yeah. So then how come we can use it for children and not adults? So the question is, the issue is BCG and the Mantoux test, they cross-react. If you've been immunized with BCG, there's a chance that your body will react and you will have a positive skin test to the TB. But guess what? That's only true for about 5 years. And since all of us were immunized at 6 weeks of age, and not again, if you're over 5 years old, there's really no cross-immunity between TB and the BCG. And if you're using it for children anyway, that's who we use the TB Mantoux skin test for. Those would be the ones that have the highest risk of cross-reacting. So that's the argument I hear the most commonly, and it doesn't make any sense. The other argument is, who has another argument? Why don't we give Mantoux skin test in adults? I want to hear my second favorite one. Yeah. I heard it, I think. What? Yeah. The other argument I heard is, well, we don't do the skin test in adults in South Africa because they're all positive. Well, then why are they positive? No, not exposed, infected. It's because everybody is infected with TB. If everybody's infected with TB, everyone should be treated for TB. That's the only way we're going to control the epidemic of TB in South Africa, is to cure the infections that are going on. And right now, it's not the guidelines. They don't do it. Now they're starting to do it in those who are HIV positive. But even those who are HIV negative, if you have a positive skin test, there's a good chance that you'll get symptomatic at some point in your life. And also to decrease the spread to others, if you do become sick, you should be treated. You should be treated. So, I'm glad I teased out of you the exact answers I wanted to hear. Yeah. So, as I said, the BCG, it may result in a false skin test, but this wanes with time, and by about age 5, it doesn't matter. Okay. So, this is the proper way to do a TB skin test. You inject it, it's best in the forearm, and it needs to make this little bubble. You see a little bubble on the arm called a wheal? If you inject it too deep in the skin, it doesn't make that, and then it's not a valid test. So it needs to make this little bubble when you are putting it in the arm. Okay. And then this is what is deemed a positive test and a negative test, and depends on the size of the reaction Not that initial bubble, but what happens 48 to 72 hours later, what is remaining on the arm. And if it's over 5 millimeters in close contacts with a known or suspected TB case, well, that's most people in South Africa, or immune suppressed. So anybody HIV positive or has a known contact with TB, anything over 5. Okay. Anybody over 10, if you have chronic medical illness, or infrequently exposed to HIV, like homeless, illicit drug, nursing homes, institutionalized, or living in a high-frequency area, which is South Africa. So anybody over 10 is a positive here in South Africa. Okay, so this is a test for you all. We've done that. We know that anything over a 10 anywhere in South Africa is a positive. And we have a skin test here. So this is 1 centimeter, which would be 10 millimeters. This is a reaction at 48 hours. Is this a positive or a negative? How many people say positive? Hand up high. Trick question. You know all my questions are trick question. You can't tell. This is a photograph. It's a photograph. We don't measure the redness. It's the induration. It's the swelling. So it doesn't matter if the whole arm is red. That's not what matters. It's the swelling. So then how do you measure it? Well, I'll show you how I measure a Mantoux test. I'll take a pen and run it down the arm. And when the first induration comes, you'll feel a bump. And the pen will stop writing. And then you take it from the other side, and you'll feel the swelling come, and it will stop. And that's the other mark of induration. Then you measure between those two lines, and that's the measurement of the Mantoux test. If that's over 10 in anybody, it's positive. If it's over 5 in somebody known to be exposed to TB or in an HIV positive person, that's a positive test. Okay? So it's the swelling, it's the induration, and not the redness. So that was a bit of a trick question there. So a negative skin test does not rule out TB, does it? As we said, up to 10% of people will have a negative skin test, even if you're HIV negative. 50% of people with miliary or TB meningitis will also have a negative skin test. Okay? And 10% of those children still may not react. And we know those that have had have low immune systems, HIV positive, with very low CD4 count, also have a smaller chance of reacting. So a negative skin test doesn't rule out TB. So then why do we do it? Why is it helpful? If a negative test doesn't mean you might still have TB, you might not have TB. So then what's the point of doing this? Because what does a positive test mean? It means you have TB. So although a negative test might not mean you're positive or negative, we're not sure, we'll have to do other tests. A positive test means you're positive, or at least you were positive at some point. Because if you were treated, your skin test will still remain positive. Your skin test will still remain positive, even if you've been treated for TB in the past.
And in that case, what would it be done in terms of treatment?
Well, in terms of checking to see if they're cured, it would be wherever they had TB. If it was TB of the lungs, you would check a sputum or X-ray. But if a person's had TB in the past, then doing a skin test is useless because you know they've had TB in the past. Okay. So TB, the skin test positive means that if you've never been treated for TB, it means you have TB infection. If you were treated, it means that you just had TB in the past. You might actually have it again, but you won't actually know that. So there are factors that decrease the response to the test itself. So infections, other infections, or other vaccines, particularly live viruses, decrease the chance of responding to that test. Chronic disease like malnutrition, lots of our children are also malnourished, so they will not respond as well to the treatment. Immune suppression, particularly HIV, which we know about, or other malignancies, cancer, chronic heart disease. Certain drugs like steroids can decrease the responsiveness of the test. The very small children and very old adults also don't respond as well. And if they have disseminated TB, as they said, miliary TB or TB meningitis, don't usually respond to the skin test as well. Now, there might also be problems with the test itself if it's not stored properly or it's not administered properly. As I said, if it's administered too deep in the skin or not enough is given. So it's not the best way, and it's not the only way to diagnose TB. It's part of our tools that we can use, but it's not everything. There are other ways to diagnose TB other than the skin test. We can use a chest x-ray if they're having chest symptoms. As I mentioned, hilar lymphadenopathy is very common, but they can also have pleural effusions, infiltrates, cavities. All of these things can commonly be seen in patients with TB. HIV patients with advanced disease, dissemination is more likely, so it's usually spread throughout. You might even actually have a normal x-ray if they have a very low CD4 count because they don't have enough immune system for it to show up on the x-ray. So patients with very low CD4s, less than 200, chest x-ray, even though they have TB, is often normal. So an x-ray still can't definitively diagnose you with TB. So the skin test might be positive and might be negative. You could still have TB. You can have a negative skin test, still have TB. You can have a normal chest x-ray and still have TB. So what else can we do? Well, we can do sputum stain. If you're coughing, if you're producing sputum, and you cough it out and you look at it under the microscope and you see TB, well, that's probably the best way of diagnosing TB. You physically see it with your own eyes. So it's a very good way of diagnosing TB. But does everybody with TB have pulmonary TB? No. Does everybody with pulmonary TB make sputum? No. So can you have a negative skin test, a negative x-ray, and a negative sputum and still have TB? Yes. Yes, it's positive. So what if you're having TB of the lymph nodes? All those things can be negative. TB meningitis, all of those things can be negative. TB of the abdomen, all of those things can be negative. So you could do, if it's TB of the lymph nodes, you could do a biopsy. Again, you take the lymph node, cut it out, look at it under a microscope. You see TB in there. Very good way of diagnosing TB. For TB meningitis, you do a lumbar puncture. You look at the spinal fluid. If you see TB in there, very good way of diagnosing TB. So there are other things, and all of these things are just pieces that help you to diagnose TB. Not one of them is better than the other. Not one will definitely tell you versus another. But you need to use all of them to help make the diagnosis. Now, this is something that happens very, very commonly. Now, this is, you can diagnose TB without any of these tests whatsoever. And I do it all the time. Not because I'm a, extra doctor. I am not super powered. I can't see TB with my eyes. I don't have any special skills, but what I can do is read the TB guidelines that were released in 2000 of South Africa. And it says that you can diagnose TB clinically. You can clinically diagnose somebody with TB with no tests whatsoever, except maybe examining them, asking them a few questions. You can diagnose TB. How do you do it? You simply do a scoring system. And this is taken directly from the 2000 South Africa TB guidelines. But nobody uses this. How do I diagnose TB clinically? I use this. But hardly ever does anyone else use it. I don't know why. It's in the TB guidelines from 2000. So you simply score things. Things will give you different points. Okay? So how long has the person been sick? You can get 0, 1, 2, 3, 4 points. Are they malnourished? What is their percent weight for age? If they're not malnourished, 0 points. Slightly malnourished, 1 point. Severely, less than 60%, 3 points. Family history of TB, no history, 0. Reported by the family, 1 point. Known positive Sputum contact, 3 points. TB skin test positive, 3 points. Malnutrition that doesn't improve within 4 weeks of treatment, 3 points. Unexplained fever, no response to treatment, 2 points. Things you can get just by exam. Local lymph nodes, joint swelling, abdominal mass, abnormal CNS findings, or abnormal CSF. All of these things, whatever they have, you simply add them up. Okay? And a score of 7 or more indicates a high likelihood of TB. So, you have a 5-year-old child who's had 5 weeks of cough. 5 weeks, 3 points. He has fever and not better with antibiotics. Fever, no response to treatment, 2 points. 5 points already. Within the first 3 sentences you asked the mother. He's been coughing for 5 weeks. Have you had any treatment? Yes, he went to the clinic, he got antibiotics. Is he any better? No. 3 questions. You've got 5 points already. Took 10 seconds. Reported family history of TB in this child. Okay, my next question. Anybody in the family have TB? Yes. Okay, that's either 1 point or 3 points. Do we know if that person had positive sputum? I'm not sure. Okay, 1 point. We're already up to 6. And the child is malnourished, 70% weight for height. It's only improving somewhat on exam. So, gets 1 point, already has 7 points. Does this child have TB?
Yes.
Very high chance of this child having TB. Positive contact, sick for 5 weeks, unexplained fever, malnourished. This kid has TB. How long did it take us to diagnose that kid with TB? Less than a minute. Took 4 questions. If the mother said, oh yes, I had TB, my sputum was positive, well, that would have given him like 9 points. So does this child have TB? Very likely. Can you send him out of your clinic without TB treatment? I think it would be hard to do. Particularly say this child was HIV positive, it would be hard for me to send this child out of my clinic without TB treatment. He's already had courses of antibiotics, he's not better. It's been going on for 5 weeks. He's malnourished, had a positive contact, HIV positive. Doesn't even say that here, but say he's HIV positive. Very high chance of having TB. I would not let this child leave my clinic without TB treatment. So we didn't get an X-ray. We didn't do sputum. We didn't do skin test. We didn't do anything. We diagnosed it clinically. This is taken directly from the guidelines. I have a few more examples here, so this is another one. But again, you know how to do it. A score of 7 or more is suggested of TB. So, the child has TB, we treat them. Right? 2 months of intensive phase. In adults, we use 4 drugs: isoniazid, rifampin, pyrazinamide, ethambutol. And then 4 months of continuation phase, usually isoniazid and rifampicin. In children, we don't use ethambutol. We use 3 drugs: isoniazid, rifampin, pyrazinamide. Why? Why don't we use ethambutol in children? Anybody know? Toxicity? What's toxicity? That is correct. Do you know what it is? The most common toxicity from ethambutol, somebody's pointing to their eyes, exactly. Is toxicity of the eyes. It can cause problems with the vision. The most common thing is it can cause problems with color blindness. It's the first symptom that you typically get. It can cause what's called an optic neuritis, or inflammation of the eyes. And the most common first symptom that you get of that is color blindness. It's color blindness. So in a small child, say a 5-year-old child, would he be able to tell you that he's not seeing colors properly? No, he may not know his colors yet. So it would be hard for him to say that red and green looks the same to me. I can't tell the difference. But an older child, 12-year-old child, does he know the difference between red and green? Would he notice if things are not starting to look right? So can a 12-year-old child get ethambutol? Yes. So that's what's recommended is age 12. Now, I'm not sure about you guys, but I have a 4-year-old daughter now, but at age 3 she knew her colors of red and green. And she could tell me what was red and what was green. And she's 3 years old. Of course she's my daughter, so she's clever, but I don't think she's that clever. Right? So I think most 3-4-year-old children know what red and green is. And so could tell you that it's the same. You could test them. So can you use 4 drugs in a small child? Yes, I think you can. Particularly those with severe disease. Those with severe disease, like TB meningitis, TB abdomen, miliary TB, disseminated TB, should get 4 drugs. Why is that? Because I think 4 drugs kills the bacteria much faster, much less chance of getting resistance. And these are very severe types of infections that can be fatal. And I think you're always, as I said in the beginning, everything we do, we're weighing risks and benefits. What is the risk of only using 3 drugs? Well, maybe the child doesn't respond as fast, doesn't get better as fast, and maybe he could die. And what if we use 4 drugs? You might develop color blindness. Would you rather be dead or colorblind? I think I'd rather be colorblind than dead. So you're weighing the risks and benefits. So in somebody who's very sick, you can use 4 drugs. So an older child who knows their colors, who's reliable, can talk to you, 7-year-old, 8-year-old child, I would be very comfortable in using 4 drugs. So, but I know the guidelines say 12, or actually they say 8, I think, the current ones in South Africa. But I think you can use for younger children as well. Okay. So HIV-TB co-infection. It is recommended, well, this is the old guidelines. This is not true anymore. With the new guidelines, most patients who are HIV-TB co-infected should start within 2 months of ARVs. We no longer are waiting to complete the course of TB treatment before starting ARVs in anybody. The reason we don't do that is because they die. Research has shown that if you wait, finish the TB treatment, and then start ARVs, they die at a much higher rate than those who started TB treatment and then ARVs within the first 2 months. So anybody, regardless, should not wait until they complete TB treatment. If they qualify for ARVs, they should start them within the first 2 months. If the clinical status is not stable enough to wait 2 months before starting ARVs, a delay of 2 weeks should be considered. And as you remember, I'm not sure if I have it here, in this graph, this is taken from the guidelines. If they're stage 4, we should wait 2 weeks. Anybody with severe immune suppression, CD4 less than 100, should only wait about 2 to 4 weeks before starting treatment. Anybody less than that, I cross out this one. Anyone who has a higher CD4 count but still qualifies, say a woman who's pregnant, would have a CD4 less, or actually anybody with TB, CD4 count less than 350. So you have a CD4 count of 349, I would wait 2 months. 2 months on TB treatment, then start ARVs. Not wait until TB treatment is complete. Okay? So, why 2 weeks? Why can't we just start them both on the same day? So drug-drug interactions, what else? Iris, immune reconstitution syndrome. What else? Toxicity. It's mostly because if we start them, I diagnose a person today with TB and HIV, CD4 count, say, is 200. Okay? So, by guidelines, we should wait, okay, not say 200, say 50. CD4 count is 50. We should start within 2 weeks, right? What if I started his TB treatment and ARVs today? Same day. Why not? So, okay, I'll wait. Everyone's saying, you can't do that, you can't do that. So I'll wait 2 weeks. I'll wait 2 weeks. Could he still get immune reconstitution syndrome? Yes, he could. He could. Because it's taken more than 2 weeks to kill off all those TB bugs. So you could still get immune reconstitution syndrome. You could still get it from something other than TB. The main reason why you wait 2 weeks is because of side effects. It's because of side effects. If I start TB treatment and ARVs today in that person, and he develops a rash, what medicine is causing it? I've started 7 drugs in one day, right? 4 TB medicines, 3 ARVs, probably Bactrim as well, 8 medicines. Which medicine caused the rash? I started 8 medicines today. I don't know. Could be Bactrim, could be Stokrin, could be Nevirapine if I started Nevirapine, could be isoniazid, could be rifampin. They all cause rash. If I start 8 drugs today, and the liver function tests come very high in 2 weeks, which drug caused it? The ARVs? TB treatment? Bactrim? Don't know. That's the main reason why we wait 2 weeks. So could you wait 1 week? Yeah. Because most of the side effects would come out by then. So in patients who are hospitalized, I think a patient who I do it less than 2 weeks, patients who are hospitalized, they're constantly being monitored. Doctor sees them every day. Nurses see them several times a day. So if they're developing a rash, they're developing jaundice, they're developing a problem, it will be picked up right away. So in those patients, I usually start them in about a week or a week and a half. You can even do it closer together. So there's nothing magic about 2 weeks. The reason that we pick 2 weeks is by then most of those side effects, rash, liver toxicity, if they're not tolerating, if they're vomiting it up, they're having some sort of intolerance or toxicity, you'd pick it up by then. That's the reason for 2 weeks. Okay. The reason for 2 months is because at 2 months' time, what happens with TB treatment? We go from 4 drugs to 2 drugs. Less chance of drug interactions. Less chance of having too many side effects. That's why we do that at 2 months. There's nothing magic about 2 months. That's the reason that we switch. So it's less drugs taken together. So that's somebody who's diagnosed with TB, HIV same time. What if they're already on ARVs and develop TB? Although their risk is lower of developing TB on ARVs, it still happens. So the important thing, as we talked about in the resistance lecture today, is the drug-drug interactions. The biggest one, as Lynn told us this morning, is rifampin or rifampicin. As she said, rifampin tries to increase and increase and increase some of these enzymes inside the liver. Whereas some of things, like the protease inhibitors, are trying to decrease that enzyme. And so they're fighting against each other. And that fighting against each other increases the level of rifampin and decreases the level of some of the ARVs. Well, it decreases nevirapine pretty significantly. In some studies, up to 37 to 58% of the blood levels are decreased. So if you're taking 200 milligrams of nevirapine and you're also taking rifampin, the body only sees 100 milligrams. It's like taking the medicine half the time. Does that put you at risk for resistance? Yeah, it sure does. You're only taking the medicine half the time. Or that's what the body sees, right? If you're taking Stokrin, it still decreases it. It still decreases it, but much less. Anywhere from 13 to 26%. So we don't change the dose of Stokrin because it is a small effect and it doesn't seem to matter much clinically. Nevirapine is very, very serious. So what should you do if a patient is on nevirapine? Well, some people have said, well, if it sees half the medicine, why don't we just increase the dose of nevirapine? Give them an extra 100 milligrams a day. That would negate that, right? Extra 200 milligrams a day would negate that. Right? Sounds like a good idea. The problem is when you do that, what's one of the major side effects of nevirapine other than rash is liver toxicity. Side effect of a lot of the TB medicines is liver toxicity. So nevirapine at a high dose TB treatment leads to liver toxicity and a much, much higher risk. So it's not recommended. So if they're on nevirapine, develop TB, they should switch to Stokrin. It's safer. Less chance of developing liver toxicity, less chance of developing resistance. So what about the protease inhibitors? And as Lynn told us this morning, the story is much, much worse for the protease inhibitors. The one that we use here in South Africa is lopinavir-ritonavir, which is Calitra or Alluvia. Look how much that is decreased by. 75%. So if I'm taking my treatment today, it's like me only taking 25% of it. It's like me taking it 1 every 4 days, right? Does that give you a high chance of developing resistance? Sure does. Sure does. It's like being underdosed by 75% at a higher dose, right? So that should work. Are there problems with that? Yes, it can also lead to increased toxicity. So some people say, well, we should just add ritonavir, because remember what Lynn told us this morning, the job of the ritonavir is to decrease that enzyme in the liver that's trying to chew up our medicine. So if we do that, that has the same effect of like boosting our levels by giving us more of that drug. But the problem with that is, one, is ritonavir is not easily available, and it's not tolerable as easily. It has a lot of problems with nausea, vomiting, diarrhea, upset stomach. In children, it comes in a liquid form that is really unpalatable. So if they don't take it at all, they'll spit it out. They'll spit it right in your face because it tastes terrible. So the more practical thing to do, and I think what most people are doing, is doubling the dose of the Calitra or Alluvia to compensate for this. Okay? So the drug-drug interactions between rifampicin and Calitra and rifampicin and nevirapine mean you need to do something about it. You need to address this. And why does this occur? Well, this is a problem because of the way the healthcare system works in South Africa. In most clinics, you go to Clinic A for your ARVs, right? But for TB treatment, you go to Clinic B, right? Different clinic. They're not linked. So what happens if somebody's on ARVs and develops a cough? They go to the clinic, different clinic. They get their sputum checked. It's positive for TB. What does the clinic do? Start TB treatment. Do they ask you if you're on ARVs? No, they don't. Do they ask you if you're taking nevirapine? No. Do they ask you if you're taking Calitra? No. So then when are we going to find out that you're taking TB treatment and these things? Yeah, when you're sick, when you have toxicity, or when you develop virologic failure, or hopefully when you go to the ARV clinic next. If you go to see the ARV clinic, hopefully they ask you, are you taking any new medicines? Have you been diagnosed with TB? If they don't do that, it may not get picked up until 6 months, you get your blood drawn, and your viral load is 10,000. And you're resistant. Can this happen? Does this happen? Yes. I've seen several children. This happened to me, and I feel terrible about it. Because what happened is one of the children that I care for at Don Mackenzie was on Kaletra. He was a young child, less than 3 years. Went to the clinic, was diagnosed with TB, was put on TB treatment, but was taking Kaletra. I was not in the office the next time the child came. I was away. Saw one of my colleagues. Not to fault them, but they didn't ask them about, are they now taking TB treatment? And so I went a whole another month, went 2 months taking TB treatment and ARVs, Kaletra, without an increased dose. When I saw the child, I noticed their weights gained, and I said, are you taking TB treatment as well? And they said, yes. I said, oh, did the clinic ask you about it and tell you to increase your Kaletra dose? No. So for 2 months, that child was taking TB treatment and Kaletra at an improper dose. And that child ended up developing resistance. Had to be switched to second line. Through no fault of their own, they were taking treatment exactly as prescribed, didn't miss doses. But the clinic didn't ask. Other doctor didn't ask whether they were taking TB treatment. 2 months of too low, of 75% decreased Kaletra can lead to resistance. So what happens? You need to ask the patients, are you taking TB treatment? Have you been to the clinic? Have you been sick? And the TB clinic also needs to be asking, are you on ARVs? If so, are you taking nevirapine or Kaletra? If so, we need to talk to your ARV doctor and switch something around. Okay. So the recommendations are, if they're on nevirapine, they switch to Stokrin. If on Kaletra, double the dose of Kaletra. If you're already on Stokrin, no changes. Remember that both of these medicines can have liver toxicity, so these patients should have their liver function tests monitored while they're on treatment. If you have latent TB infection, it is recommended that patients take isoniazid. Children take 5 to 10 milligrams per kilogram per day for 6 to 9 months. The South African guidelines, they give 5 milligrams per kilogram for 6 months to children under 5 with the sputum. Research studies in South Africa have shown if you give children isoniazid therapy and they're HIV positive, it saves their life. They live much longer than children who do not receive isoniazid. The studies were done in South Africa. It's been proven. We know it's true. Those children that have a positive skin test live much, much, much longer than those once they receive isoniazid versus they don't. But it's not been put into practice yet. It was in the guidelines in 2004. Several research studies from the early 2000s have shown it to work, but it's not been put into practice yet. And I don't know why. It's now mentioned again in the 2010 guidelines, I think with a little bit more emphasis, so hopefully it will be put into practice. There's no significant interactions with isoniazid and the ARVs. It's the rifampin that does it. So you're safe to give children on Kaletra, on nevirapine, whatever. It's safe to give them 6 months of isoniazid. So there's not much drug-drug interaction. It saves their life, it prolongs their life, decreases their chance of getting TB. Something we should be doing. Okay. TB in pregnancy. All pregnant mothers should be screened for TB. We talked about this in the PMTCT guidelines. It should be part of routine prenatal care. All pregnant women screened for TB. If they can be screened clinically, they can be screened with a Mantoux test, they can be screened with sputum, however you like to do it. Because the risk of a breastfeeding infant in a mother who is sputum positive is very, very high, isn't it? Think of where the mother holds the child, right? And she's breastfeeding, and she's coughing. Where's the child? Think of the picture of the man sneezing. Think of those germs. Where do they all land? Right on the child. So that risk of a breastfeeding child and a sputum-positive mother is very high. The risk in an HIV-exposed child, even higher. So mothers definitely need to be screened for TB. So this is the current recommendations for children with TB. So a newborn of a mother with TB, if the child is well, gets isoniazid and remains well, they still get their BCG vaccine at 6 weeks of age. If they're symptomatic, the BCG should not be delayed in TB exposed on isoniazid or TB. Then you consider full TB treatment. They should still get their BC vaccine, but instead of just isoniazid, they get full treatment. And any child with a mother with TB who's symptomatic gets full TB treatment. So only if they're asymptomatic do they get isoniazid only. If they're symptomatic, if they have abnormal chest X-ray, then they get full TB treatment. Okay. And just a little bit about BCG. In the majority of cases, children are asymptomatic, and so they can still get the BCG. So we see quite a bit of this. So this just goes through the story of what I just explained. A 2-month-old child comes to the clinic for the first time, has never been to a health center before, was born at home. The baby has not received any immunization so far. The child is now sick with a cough, fever, bleeding mucous membranes, respiratory distress. Mom tested HIV positive during her pregnancy. Should this child get BCG? No. Symptomatic HIV should not get it. So the child is sick at this visit, is likely symptomatic, should not be. So, a few things I've added about TB prevention, because I don't think, I know, that we don't do enough prevention in South Africa. So in terms of prevention, there's really things that we need to do. So for contagious infectious disease, so patients with cavitary pulmonary disease, some people are much more contagious than others. Adults are more contagious than children. If you have pulmonary TB, you're much more contagious than somebody with extrapulmonary TB. And most patients with extrapulmonary TB aren't contagious at all. So if somebody has cavitary lung disease, apical pulmonary TB, they are very contagious. If you have positive sputum, they're also contagious. Positive sputum means you're coughing, you cough up sputum, you can see TB in it. That means that when you're coughing at other times, TB is spreading throughout the air. So they're also very contagious. And if you have extensive pulmonary disease, they're also contagious. Keep in mind, most children, particularly young children, are not very infectious. So there's things that we can do to prevent infection. I thought I added it into this lecture today. And it's referred to as the main things that we do to prevent infection or dissemination are isoniazid preventative therapy. Anybody with a positive skin test should be treated. Should be doing contact investigation. Those patients who have TB, contacts should be screened for TB and treated if necessary. There's also personal protective devices and controlling it within hospitals, within clinics. People who are known to have TB or are coughing can be put a mask on. Staff members who are HIV positive, going and working in a TB clinic or hospital, they should be wearing masks. All of these things can help to reduce dose. Isolating patients is a very important and very effective way of reducing the spread of TB. But we don't, most hospitals aren't designed to. Patients are put in wards instead of isolated. In the United States, the patient is even suspected of having TB. Somebody suspects that they may have TB, they're put in an isolated room all by themselves. With negative pressure, vents towards the outside. Even if they're suspected of having TB. They get their own room, it's negative pressure, anyone walking in has to wear a mask. The room is ventilated and everything gets put through a filter and goes outside. Here, we have known sputum positive patients and a huge ward with sputum negative patients. TB patient lies next to an HIV positive, TB negative patient on the ward. not wearing a mask, not doing anything. I've had sick patients on the wards, HIV positive patients, admitted for something else. They were TB negative when they were admitted to the hospital. They were TB positive when they were discharged from the hospital. They caught TB in the hospital. So we're not doing enough to prevent the spread of TB inside the hospital, inside the clinics, and even in the community. So I just wanted to end up with this X-ray, a few X-rays of TB and of things that may look like TB if you see some X-rays. So this is a patient with TB and a high CD4 count. As I said, TB in a patient with a high CD4 count is most commonly reactivated disease, upper lobe disease, like in this patient. TB in a patient with a low CD4 count acts much more like a child. They're commonly high lymph nodes. So that would be primary disease, high lymph nodes in a patient with a low CD4 count. Patients can have cavitary disease. This is more commonly reactivated disease, much more common in adults. This is a normal X-ray. This one, these patients have, see these circles, these are cavities of TB in the chest. This is a normal chest X-ray. This is a patient with TB, a left lower lobe pneumonia. This looks just like a bacterial pneumonia, but it was actually TB. Can't tell the difference just based on the X-ray. This is a patient with PCP. This is normal with PCP. This looks like disseminated TB, biliary TB. You really couldn't tell the difference if you were doing two X-rays. This just happens to be the patient with PCP. Again, this is another PCP. This could be TB. This could be biliary TB. They look very similar. So you see this one. This is a biliary TB patient. And this is PCP. They look very, very similar. This is a patient with TB pericardial effusion. They had very large hearts. They removed the extra fluid, and you can see what actually happened was the line of the heart was stiff. It was stuck with TB. And then this is the heart itself. There was air left in the pericardial TB. TB, you remember, can cause meningitis, which can cause severe brain infections. And pulmonary capillary sarcoma, which in this case it looks very, very similar to severe TB. And if you just showed me the X-ray, I wouldn't be able to tell you this was pulmonary capillary sarcoma versus TB versus PCB. They look very, very similar. So I know that was a lot in a little bit of time, or a lot of sessions. I'm going to give you the highlights. I think the most common things that you see, the most common things that you deal with when you get into HIV and TB. Questions?
How to cure TB meningitis? How to cure TB meningitis?
The cure for TB meningitis is the same for regular TB. It usually involves 4 drugs, but usually for a longer period of time. The treatment is usually for 1 week instead of
the abdomen one.
It depends who you ask. There's brand new, those of you who are interested in TB, brand new TB guidelines came out from the World Health Organization on Wednesday. There's brand new TB guidelines that came out from the World Health Organization on Wednesday this week. I haven't read them. So some people say TB abdomen should get 10 months. Some people say 6 months. I don't know what the new WHO recommendation is. Some people say that TB abdomen in HIV positive patients should get 9 months. Some say for ARDs it's only 6 months. There's not a very good answer